next lecture on thyroid. So that is thyrotoxicosis. Last time we have seen what is a solitary nodule. We have seen how does a euthyroid thyromegaly behaves in the form of solitary nodule or in the form of a multinodular goiter. Now we will see something of a complication that develops in a long-standing goiter, or de novo the thyromegaly has a pathology in the form of thyrotoxicosis. So can anybody tell me what you mean by thyrotoxicosis, and have you heard a term which is similar to thyrotoxicosis? Anybody? What is thyrotoxicosis? What is the impression about thyrotoxicosis? And have you heard about any term which is similar to thyrotoxicosis? Yes, thyroid storm, okay. Have you heard of a term called as hyperthyroidism? Anybody? So do you think these are interchangeable, thyrotoxicosis and hyperthyroidism? Or they are similar, dissimilar? Many times you'll say in the ward, in the case of hyperthyroidism, 9131 ward, 12 number patient. Somebody will say that there is a patient with thyrotoxicosis, for the same patient. So they use this sort of terminology. So do you think it is correct, incorrect? What is the difference between the two? Anybody? Yeah, can you tell me? Thyrotoxicosis. In simplified terms. Simplified terms? Anybody else? To make it very simple to understand. Okay, because it's a little difficult topic to understand, but if you understand it well, you will not fail. Anybody? What can be the difference between hyperthyroidism and thyrotoxicosis? When I say that they use interchangeably, they are not very much wrong. Now you tell me the reason for that, these two. They are not very much wrong. Why? Just now I said both are not same. But if you use interchangeably, you are not absolutely wrong. Reasonably correct. Not fully correct, but reasonably correct. Right. This side. Okay. No, not like that. As I said, it's a patient. It's not only symptoms. It's a disease. This is also disease. That is also disease. What is the difference? This side. Anybody? Okay. Let us see in the next slide. Try to understand this very carefully. Is there that fellow Colin? Is there outside? Okay, now we can see here what somebody said. The first half of the answer was correct. Hyperthyroidism means there is increased level of thyroid hormone in the body. Hyperthyroidism means there is increased level of thyroid hormone in the body. Thyrotoxicosis also means there is increased level of thyroid hormone in the body. So the first half of the definition, first half of the terminology for the disease is same. The second part, there is a difference. What is the difference in the second part? Second part, the difference is that when it comes to hyperthyroidism, the raised level of the hormone is coming entirely from the thyroid. Entirely from the thyroid. Thyrotoxicosis, the raised level of hormone is again coming from the thyroid gland. Again coming from the thyroid gland, but not necessarily always from the thyroid. So now give me an example, this half of the class, where the thyroid is normal, not producing excessive hormone, but the body has high levels of hormones. One example. Last four, this thing. Then last row. Two girls are sitting there in the last row. One of you tell. Give me one example where the thyroid is not manufacturing increased level of hormone, but the body has got high levels of hormone. What could be the cause? Okay, this side, first row, anybody can answer.
Paraneoplastic.
Huh?
As a paraneoplastic.
There is?
Paraneoplastic.
Paraneoplastic syndrome. Okay, accepted.
Ectopic thyroid.
Yes?
Ectopic thyroid.
Ectopic thyroid, just producing. Accepted. Anything else? Simpler. You people are experts in pharmacology. Now tell me. Huh? Yes, somebody is taking, thyroid is always prescribed once a day. Thyroxine. But we have a habit of writing everything TID, QID. Is it not? It has happened. Once you people pass, you become interns when you sit in the OPD. By mistake, if you do not know, remember this point, you will write down the thyroid dose as whatever dose, and say give 100 micrograms to the patient, you will write 100 micrograms QID. So the patient should receive 100, but now the patient is receiving 400. And thyroid we give for a long period of time, 2-3 months, and then evaluate. For 3 months the patient is getting 400 micrograms. Next time the patient comes with florid symptoms of thyrotoxicosis or hyperthyroidism. Hyperthyroidism is incorrect. It is not coming from thyroid. Now you see the difference. All of you understood? Any question anybody wants to ask? We'll see in the next slide. What are the other causes of raised level of hormones? But this is the basic difference. Thyrotoxicosis you get from. That is why I said why interchangeability is reasonably correct. 90% of time in thyrotoxicosis, the hormone level is coming from the thyroid. Very few times it will happen that some other reason is there that the thyroid hormone has. Understood? All of you understood the difference between hyperthyroidism and thyrotoxicosis. So now, if you get a case of thyrotoxicosis in the exam, or I'll use the term interchangeably, hyperthyroid. What you get a case, they will ask you what is the diagnosis. Let's say not exam, but you are examining the what also. 95% of the times, 95% of times, the diagnosis will fall within the top 3, which I have put in bold. What are the top 3? One is Graves' disease. Number 2 is a toxic multinodular goiter. And the third is what I told you last time. Third, what I taught you last time. What did I teach you last time? Solitary thyroid nodule, which is euthyroid. Once in a while, this same solitary thyroid nodule can be toxic. Understood? So, is it difficult to make a diagnosis? No. Because you know the 3 conditions where the diagnosis will. I will tell you slowly how to differentiate between the 3. It is very easy to differentiate number 3 from the others. Yes or no? Your diagnosis is STN. What is the definition of STN? So, how will you define a solitary thyroid nodule? Yes, it's a single nodule which is palpable in the thyroid. Single discrete nodule palpable in the thyroid when the rest of the thyroid is not palpable. So you have palpated the thyroid, you find one nodule, you diagnose STN. Patient has got toxic symptoms. What's the diagnosis? Toxic. Very easy to diagnose. Problem is between 1 and 2. 1 and 2. We'll see how do you differentiate between 1 and 2. But you got it? Commonest cause, very easy to diagnose. 95% of time will fall into that. So if you get a patient of thyrotoxicosis, there should be no reason why you cannot diagnose it at your level right now. 3 conditions are. I'll tell you how to differentiate between 1 and 2. So what are the 3 conditions? Again I'll repeat. Graves' disease, diffuse toxic goiter. Other term is also used as primary thyrotoxicosis. Whenever we say primary, what does it mean? Primary means? Primary means the gland is at fault. The gland is at fault. Primary means the gland is at fault for that disease we are talking. Secondary means the gland has got some pre-existing disease on which a superadded complication in the form of thyrotoxicosis or hyperthyroidism, whatever it is, happens. You see the difference? Normal thyroid becomes pathological and toxicity develops. The pathology is toxicity only, nothing else. Primary thyrotoxicosis. Pre-existing disease, multinodular goiter is there, choroid goiter, 10 years. Patient never had toxicity. But now last 6 months or 1 year, patient developed toxicity. What is it called as? Secondary thyrotoxicosis or a multinodular toxic goiter. The other name for this is, first one is called as Graves' disease. Somebody must have described the other one also. Number 2. Does anybody know what is the name of the second? This side. Who described? It is called as plumber's disease. P-L-U-M-M-E-R. So Graves' disease, primary. Secondary is plumber's disease. Okay. Sometimes, I told you this TID, QID business. If a patient is taking a lot of exogenous thyroxine, patient will develop thyrotoxicosis. What is that called as? Number 4. Thyrotoxicosis factitia due to excess exogenous thyroid hormone supplementation or administration. Thyrotoxicosis, this is really thyrotoxicosis, not hyperthyroidism. Thyrotoxicosis factitia. Now, let us presume that a person is staying in Himalayas, hilly region. What is the problem in hilly region? Nowadays it's not there, but usually hilly region, what problem people can face? What will happen? Iodine deficiencies. Nowadays I said it's not a problem because government is supplying iodine salt. But let's say the person is not taking it. Government might be supplying iodine salt, but there's a possibility people might be selling that salt, what like they make now, we go to Chennai, there are areas that prepare salt directly. And that is cheaper, they'll sell it in a sack, not in a proper packet. So that might not have iodine. They might consume that only because that is cheaper. Something like that happens, what will happen? Iodine is not there. This is the thyroid gland. Physiology, what will happen? In a thyroid gland, it has to, let's say, produce per day 10 units of thyroxine. There is no iodine to supply. It has to produce 10. So thyroid, what it will do is, it will become big in size. So because let's say initially it had 10 cells, now it will become 50 cells. So 50 cells, like let's say this one, or let's say this 6 students are doing some work. They are not able to manage. Okay. If that 6 becomes 60, is it possible to manage the work easier? Manage the work, yes. Same principle here, that normal thyroid cannot manage, thyroid becomes big and tries to maintain the level of that 10 units of thyroxine per day. So when you have that sort of goiter, it's a physiological goiter, iodine related goiter, not physiological, iodine related goiter. So it's a, what sort of gland will you call that? That gland will be very much iodine avid gland. Iodine avid gland means what? It will be hungry for iodine. Is it not? Because there is no iodine. Wherever iodine it gets, it just eat it off and produce the thyroid hormone. That is why you have that diffuse hyperplastic goiter. So now imagine that person gets transferred from a hilly area to area where abundant iodine is there. What will happen to the thyroid gland? It's a huge gland. It is hungry for iodine, so it will take up all the iodine, whatever it gets. It will not bother that I have to only produce 10 units of hormone. When it eats up all the iodine, what it will do? It will produce 100 units of hormone. What will happen to the person? Person will develop toxicity. That is called as jod-based thyrotoxicosis. Jod means iodine in German. Based is a person who described, and that is what can lead to jod-based effect or jod-based thyrotoxicosis. Anybody is there who has not understood this concept? I'll tell again. You just raise your hand. That's fine. Understood? We'll go for it. All of you follow what I said? So if it is a gland which is avid for iodine, avid, hungry for iodine, and then that person lands up in a place where there is abundant iodine, and that will produce thyrotoxicosis. Thyroid gland can get inflamed. What is the commonest inflammation you know of the thyroid? This half. Yes? Hashimoto's thyroid. Yes, Hashimoto's thyroid. So what happens to the follicles in inflammation? Follicles will rupture. Okay? Inflammation, rupture. So when the follicle ruptures, what will happen to the hormones? It will get released in the circulation. So thyroiditis, what will happen? First there is inflammation. Follicles will rupture, release the hormone in the circulation. Patient will have increased levels of hormones in the body. Gland is not producing excessive hormone, but there is a release because of rupture of follicles. See the difference? It's not manufacturing extra, but the hormone what it is manufacturing normally is getting released in an excessive manner. That is what is called as thyrotoxicosis related, that is called as thyroiditis related thyrotoxicosis. It is also called as Hashimoto's Hashimoto's disease. Hashimoto and thyrotoxicosis combined, it is called as Hashimotoxicosis. Now here, how much hormone will be released? It cannot release too much now, is it not? Even if follicles rupture. So what should be the natural course of the disease? If you put a graph, the hormones will rise. If nobody has got indefinite level of follicles, one day the follicles rupture will come down because inflammation is also coming down and there are no follicles to rupture, so the hormone level will come down. Because follicles are ruptured and too much of hormone has been released, the production also has become low. What will be the next phase? Hypothyroidism. So initially mild hyperthyroidism, or thyrotoxicosis, I should use the word, no increased production. Ideally it's coming from the thyroid gland only, but then you have euthyroid phase and then hypothyroid. It all depends what stage or phase you are seeing the patient. So a thyroiditis patient can have all the things. So when the patient comes in a mild toxic phase, we give low doses of antithyroid drugs. Okay? Not antithyroid drugs, but we give low doses of drugs which act on the hormone, propranolol. Okay, beta blockers. Because there is no point giving antithyroid drugs, I will tell you later. Euthyroid phase, don't do anything. Hypothyroid phase, the patient will require what? Thyroxine. That's how we treat a patient with thyroxine. So how will you differentiate that from these things? These things? Here, the levels, increased levels are very high in the body. Patient will have florid symptoms of thyrotoxicosis. Here, the patient will have mild symptoms. Mild symptoms. Because thyroiditis cannot produce a typical florid stage of this. Okay. Even this practitioner will be usually mild. How much hormone person can take? Unless until the patient taking 10 tablets because of error, that's a different thing. Otherwise, if it is 1 TID, 1 QID, it will be in the form of mild type of. Only these first three can produce any level of toxicity. Malignancy of the thyroid very rarely produces toxicity. So when you make a diagnosis of malignancy, never say malignancy with toxicosis. What is the reason for that? Last time I told malignant cells are immature cells. Normal cell produces normal level of hormone. Immature cell will produce lesser level of hormone. So it can never produce toxicity. So why have listed it here? When can it produce toxicity? Just imagine and tell me. What can be the condition? See now, normal thyroid, let's say, has got 100 cells, which is manufacturing iodine. I said it has become malignant, immature. So 100 cells will produce, instead of 10 units of thyroxine normally, Now 100 cells will produce only 3 units of thyroxine. Because it is immature cells, they cannot produce thyroxine. So what is the problem? It is producing hypothyroidism. It's not producing normal. Or it might remain at the euthyroid stage also. So when will it produce this? Because in malignancy, it never stays at 100. Malignancy number of cells will increase. So what will happen? That 100 will become 100,000. That much increases there. So it will no longer remain only 100. It can become 10,000 or 100,000. Now 100,000 cells, if they are producing very low level of metastasis also is there, counting everything and there. Even if it produces low level of hormone, put together, what it can produce? Thyrotoxicosis. Okay. This is what is the concept of malignancy. In general, it is very rare, but once in a while, follicular carcinoma can produce well-differentiated follicular carcinoma, multiple metastases, all are producing little bit of hormone, total hormone in the body as result. Patient has toxicity. Then what you people told? Okay. This can produce paraneoplastic syndromes and then ectopic thyroid tissue, stroma movora and all. So all these are very rare conditions, just for listing stage. So ultimately you have to concentrate on these three. So any questions before I go to the next slide? Anybody has any doubt? Anybody wants to ask any query? Any point? Fine. So just now I told sometime earlier, primary thyrotoxicosis, Graves' disease. Secondary thyrotoxicosis, multinodular goiter leading to toxicity. When you have a large multinodular goiter for a long period of time. Okay, I'm saying now when I say long means it's not 1 or 2 years or 3 years, 10 years, 15 years, huge thyromegaly. In hilly areas it happens. That can lead to 3 or 4 complications. One of them is this toxicity, which we call it the plumber's disease. What are the other complications? Yes, very good. Pressure symptoms, tracheomalacia, all those things can happen. Okay. Patient can even have hoarseness of voice. Anything else? It can undergo malignant change. Which malignancy? Which malignancy? Anybody? Very few malignancies are there in fact. It cannot become lymphoma, it cannot become anaplastic carcinoma, it cannot become medullary carcinoma. Medullary carcinoma comes from the parafollicles. So what is left? Papillary and follicle. So it can become follicular carcinoma. Remember that, not papillary. Follicular carcinoma. This is for follicles no? From there. So follicular carcinoma. Those are the complications. These 3 predominant: pressure, malignancy, toxicity. That is why you are supposed to operate on this patient for multinodular goiter. Now let's see primary and secondary, what are the difference? Graves' disease happens as a primary disease, 20 to 40 years. All disparate disorders occur more often in the females. That I already told you, anything, including malignancy. So young girl is coming, 25-year-old, 30-year-old, has got thyromegaly and florid signs of toxicity. First diagnosis, Graves' disease. Let's talk of that all about. So, this is very important. What she will tell you, that I developed a swelling in the neck and I developed the symptoms of toxicity. We'll go a little later what are the symptoms of toxicity. Both the things occur together. Together means not on the same day. Monday morning 8 o'clock it will not start. Together means little overlapping. Something 4 months, 3 months, 6 months like that. She may say the swelling is there for 6 months, toxicity for 5 months. Because toxicity has started but she has not noticed. Other way around also can happen. She might notice the symptoms but not notice the swelling. So little bit aage piche, but not too much. Whereas when it is a case of secondary thyrotoxicosis, I just now told, the goiter has to be there for years to come. If the patient says, I had a swelling for 1.5 years or 2 years and the symptoms for 6 months, don't label the patient as a case of secondary thyrotoxicosis. Secondary thyrotoxicosis, the swelling always precedes by years before the symptoms are. Not 6 months, 1 year, 2 years. 2 years the multinodular goiter will not become toxic. So it will be 8 years, 7 years, 10 years, 15 years. So long-standing swelling has undergone complication. So that is the principal difference by which we identify. Symptoms mainly calorigen. We'll see this later on. Here, because the patient who has this goiter for 15 years, do you expect that patient to be a 20-year-old girl? She's not going to have thyroid from 5 years of age. So naturally the lady will be 45, 50, like that, 55. So all this cardiac, these hormones, thyroid hormones can also act on the heart and can produce predominantly cardiovascular symptoms. Signs, we'll see that. All eye signs are present, predominantly. Limited eye signs, less spasm around. This is not very important. Basically, diffuse goiter, very vascular, primary thyrotoxicosis. For nodular goiter, large goiter, some areas may be little hypovascularity, that is multinodular toxic. So that is what is the difference. So just imagine a large goiter, some focal areas of toxicity, how it will behave. A diffuse thyromegaly, the whole thyroid has got the disease of toxicity. That's why we call it as primary thyrotoxicosis, Graves' disease. That's how. You put your finger on the, if you put your the palms of the fingers on there, you will find a thrill. You put a stethoscope there, you will find a blue because of increased vascularity. Without that, the thyroid cannot produce that much hormones. Thyroid otherwise also is very vascular. Obstructive symptoms, do you think a small thyroid should produce that? So as you said, obstructive symptoms is a feature of long-standing thyroid. So that's why if you understand it very well, you don't have to remember it. And then treatment. Treatment for a small toxic thyroid goiter is you can manage with drugs or radiation. Large nodular goiter. What is the cause of nodules in a thyroid? When you cut the thyroid which you excised, the areas, the nodular areas, what will you find there on the cut section? Pathology. Glass. These 3 lines. Just tell something. What will you find? Anybody? Yes? You should find areas of degeneration, non-functional areas. You can find areas of hemorrhage. You can find areas of all colloid material. That is how it will be there. So if you have something like that, lot of non-functioning areas of the thyroid, they're just physical nodules there, non-functioning. If you give anti-thyroid drugs or radioactive iodine, do you think they'll disappear? They'll not disappear. It's like, spaces in the thyroid which no longer have any thyroid tissue. If it doesn't have thyroid tissue, if you give radioactive iodine, it will not pick up also. So the only way that sort of thing has to go is with the help of a knife. You take a scalpel and excise the thyroid. Then only the swelling will disappear. Whereas the hyper-functioning gland, the whole gland is enlarged because it is increased functioning. So you hit it with iodine, the cells can get destroyed. If the cells are destroyed, what will happen? Immediately the gland will shrink. That's the principle. Okay, understood? So this is how you manage. This is what is the difference between primary thyrotoxicosis and secondary thyrotoxicosis. Any questions from anybody? Any point? These are the concepts which you have to understand. If you understand, then later on few slides I'm going to put, that is given in the book, that is very standard and there is nothing to understand. Anybody has any doubt? Thyrotoxicosis is not a very straightforward subject, but it's not difficult to understand. Once you understand and get a grip of it, you will not fail it. So anybody wants to ask any question up till now? Fine. Now this is a little bit of something which is not very difficult to understand. You just have to read it. Described by Irish physician Robert Graves, that's why it's called as Graves' disease, common in females, that's the age. Pathogenesis, this is again to understand why it happens. The etiopathogenesis. What is the exact problem in a patient with Graves' disease? Now, okay, one of you come forward. Another person, You just open your hand like that. Put it like this, see. You come on this side. and put your fist into the sea. Okay. Now I'll keep it separate now when I tell you. Now see, this is the receptor on the thyroid gland. This fist right now is TSH. So this TSH comes, locks into the receptor. What is the function of this? From where does it come, TSH? From the pituitary, normal person. This will lock and it will tell this receptor on the thyroid to produce thyroid hormone. That is the normal. That is why in hilly areas, this thyroid hormone, not thyroid hormone, this TSH, it will become 5-6 instead of 2. The TSH level is always risen in a patient when the hormone levels are very low, because it will give a positive feedback, and this is nothing. That's how the phenomenon works. Physiological work is also like that. Young females, 18, 16, during the puberty time, they require a lot of hormone. They cannot produce. So what will happen in thyroid gland? It will increase because the TSH rises. Normal person, normal level of TSH is there. So this is what it comes there, locks there, produces normal level of hormone. Now, you come in. TSH is normal. Try to understand the concept very clearly. You stand on this. Again, make a fist. TSH is normal. Okay? He is coming from the pituitary gland. Lymphocytes in the body, they produce an antibody that is called as thyroid stimulating immunoglobulins. Okay? Thyroid stimulating immunoglobulins or thyroid receptor antibody. Now, his fist is that antibody. This antibody comes and locks them. What it produces, this action, increase the thyroid receptor does not understand this is the antibody. It feels it is the TSH and it produces increased levels of hormones. Now, when the increased levels of hormones happen, the milieu interior, the physiology of this body, what it does, it hits the TSH, the pituitary gland. You go and say. Pituitary gland reduces the TSH level, undetectable levels. He is disappeared. But the body does not understand that it is not him which is producing this, it is him. This TSIs do not get affected by increased levels of hormones. So what happens then? The hormones rise. There is no way to reduce this TSH because this is an immune reaction in a person. Because this is an immune reaction, now you go and say. There is no way we can control the immune reaction. That is the principal pathogenesis in thyrotoxicosis. That is why one of the investigations that we do is to see the levels of these antibodies. If the antibodies are very high, that indicates patient has got primary thyrotoxicosis. So you understand that now, line. Okay. It is a very, very important concept we should understand. Thyroid stimulating immunoglobulins of IgG class produced by lymphocytes stimulate TSH receptor. All of you understood the concept now? What happens in thyrotoxicosis? Primary thyrotoxicosis. This is what happens. And in spite of increased levels of hormones, the TSH it gets hit. It becomes. So then if you do a TSH test in these patients, it will be non-detectable. T3, T4, very high. That is how you will see it in a patient with primary thyrotoxicosis, Graves' disease. So what it produces in the eye? It produces this fibroblast proliferation and all these things behind the eyeball. So what will happen to the eyeball? It will come out. What we call it as true exophthalmos. See, if you just stare at somebody, you just stare, it will appear as if the person's eyeball is protruding out. If you just stare, that means the upper level of sclera should be visible. That sort of stare if you give somebody. So the other person will feel as if the eyeball is coming out. But actually that is pseudo-ectoplasm. Because the eyeball is not coming out. It's just your stare. You see the difference now? So in a patient with thyrotoxicosis or hyperthyroidism, see now I'm interchangeably using. What happens is patient can have pseudo also or actual exophthalmos. When there is not much of deposition and the eyeball is not protruding, it's only the lids which are having that stare, the patient will have pseudo-exophthalmos. When it's real deposition behind the eyeball and the eyeball gets protruded outside, it will be true exophthalmos, true protrusion of the eyeball. Remember that. So some tests are there which you can identify based on that. So anybody who has not understood the concept of pathogenesis of this, all of you follow? If a person does that 100 meters dash, okay, you are holding that rope and you are standing there. You have this interclass sports, no? So 100 meters somebody runs. So when the person crosses that rope and you meet that person, whatever the person is having, those are the symptoms of thyrotoxicosis. So what are the person will have? One is palpitation. The fellow will be sweating, is it not? Alright, then the patient, because the person is running like this, the person will be hungry, eating quite a lot. But the person will not put on weight, because the person is exercising. So these combination of symptoms are due to their calorigenic symptoms. So they are all present in this. So if you see the symptoms, they are all related to what I told. See, the fellow will have increased appetite, who does all this running business. Weight loss, naturally weight will be always slim and trim for this fellow. Heat intolerance, where the person will feel so hot that if you put the patient in a hot chamber, the person will feel further hot. Is it not? So that is all. If you do a 100-meter dash, person will want a fan. Increased sweating, tiredness. You see, all symptoms related. If you just remember that thing, 100-meter dash, you see all the symptoms are falling in line with that. Is it not? Now these patients also have tremors, anxiety, nervousness, increased activity. Okay, this is when the levels are very high. They will not be sitting on one place, they will be doing something. Okay, so that sort of thing, symptoms will happen. Then cardiovascular, all these things can happen. Okay. CCF and all those things, late stage atrial fibrillation. And ocular, as I said, diplopia, pain, increased lacrimation, corneal ulceration. What is the cause of corneal ulceration? Ophthalmos. Because of protrusion and infrequent stare. So what happens is, the eyeball should actually, the eyelid should close. No? Otherwise what will happen is that the tears also, the filming of the cornea will not happen. The cornea will become dry. When the cornea becomes dry, it lead to keratitis. Keratitis will lead to ulceration. So that is what is the pathogenesis. Then oligomenorrhea and hyperdefecation. If it is a hypothyroidism, it is the opposite of oligo. Okay. And naturally the GI motility also increases, so the patient will have this one, hyperdefecation. Signs. Diffuse enlargement with glowing and visible pulsations. I told you, when you look at the thyroid gland, the whole gland will be pulsatile like this. This is the only condition where you get that. The gland, if you look very carefully, it'll be like that. In some other patients, okay, in malignancy also sometimes there is increased vascular pattern. So you have to look at the thyroid vessel. Which vessel will you look for? If you have to look for pulsations in a non-pulsatile gland, where will you look for it? This row, first three, this 3 rows. Anybody? Where? Huh? Where? Superior thyroid artery. Any other answer? Inside superior thyroid artery, you use the term superior pole of the thyroid. Okay. Where? This side? Any other answer? Okay, give me a reason why superior thyroid. You are correct. Answer is correct. More superficial. Yes, inferior thyroid artery comes from behind. Superior thyroid artery comes from the top. So whenever whatever is superficial will be visible. But in toxic, this Graves' disease, you don't have to look at that. The whole gland will be pulsated like that. Then this thing can happen, pulse rates, sleeping pulse rate. See, patient is very anxious. I've seen many students, they will be standing in microbiology, pathology outside with a book when they have to enter for Viva. If you look at the pulse rate, it will be 110. Okay, so that is because of anxiety, anxiousness, nervousness. That leads to palpitation and tachycardia. But if a person is in general very anxious and all that, pulse rate will always be high. So what is the best way to cut off this thing? Let a person have a deep sleep. Person cannot be anxious when the person is sleeping. That is the time you take sleeping pulse rate. If the sleeping pulse rate is high, it is not because of anxiety. It is because of some problem in the patient. That is what we call it as sleeping pulse rate. That will be high. Okay. And then sometimes it can lead to this. Medicine also you are studying so atrial fibrillation and all that. That is what can lead to CCF and all those things. Okay. So that's how. That's the. Little bit about eye signs. This is actually clinical part. But little bit I'll tell. So when you are examining a patient in the ward, some background you should know why the patient has the signs. So one of them is Von Graff's sign. What do? We hold our hand like that, ask the patient to look at this finger and then drop the finger. You will find that the person is not able to follow the finger. There will be lid lag. Lid lag. That is what it's called as. That is the other term for it. So that is Von Graff's sign. Stelzach sign is what I just now told. If you look at each other's eyes, you cannot see the upper slit. So because of that stare, I'm not saying to the protrusion, because of the stare, okay, because of the stare, I'll tell you what is the cause of the stare. You can see the upper slit. When something like that is there, that is what is called as, characteristic stare with infrequent blink, Stelzach sign. Stelzach sign. Then the fissure will also, the palpebral fissure also, because of the same thing, it will become wider. That is what is called as Dahl-Rimpel sign, widened palpebral fissure. Now, can anybody tell me why all this business happens in a patient with toxicity, thyrotoxicosis, primary thyrotoxicosis? Primary. These eye signs are a feature of, we saw that column, no? Eye signs are predominantly for primary. Secondary, we get all this heart business, atrial fibrillation and all those things. Now, can anybody tell me what is the reason for this? This is the reason. Now read this. It is easy to understand. What is it? See, apparent exophthalmos. What I was telling you, pseudo. It is not actual protrusion. Due to spasm of Muller's muscle, thyroxine makes this muscle oversensitive to the effect of circulating catecholamines. What is the other name for that? Catecholamines is called as what? Sympathomimetic. No? What is the other name for that? Huh? No, what is that? Parasympathomimetic is all the vagus and all that. Yeah, tell me. Huh? Adrenaline. So that's one of the drugs, no? So anyway, so this is what it is, the thing which is normally secreted. So this is the reason for those three tests which are there. Then, true exophthalmos, the eyeball has protruded out. Now, normally, if you have to look at the ceiling, if I look up like that, what will happen to my forehead? There will be some corrugation, is it not? When I look up like that. So, Geoffroy's sign. Now let us see, I'll use this mic head. This is the eyeball. It has protruded. Because it has protruded out, the person can look up very comfortably without producing any action on the forehead muscle. Because the eyeball is out. Easily the eyeball goes up and looks at the screen. That is why the patient will have no wrinkling on the forehead when the person looks up. That is what is called as Geoffroy's sign. If the same person, you make the person sit in the chair, you stand above the person and look at the superciliary, what is it called? Notch or whatever it is called. Okay. So you look at the upper eyelid, okay, and go see tangentially both areas. What will you find? In a proptosis, you will find the eyeball protruding out. Normally you should not find. If you What is this called? Upper eyebrow, right. So if you look from the eyebrow like that, you should not see the eyebrow. Normally, if you take anybody and look tangentially, you cannot see the eyebrow. But when you run your gaze parallel to the upper eyebrow, if you find the eyeball protruding out, that is true proptosis. That is Navziger's sign. Okay, so true proptosis produces these two signs. One is that you can see the ceiling without this, and so that is Geoffroy's sign. This is Navziger's sign. Because of these hormones, see the Muller's muscle becomes spasmodic. The medial recti they become weak. So if the medial recti become weak, you cannot have much of convergence. That is what is called a Napier sign. So these are the 6 signs. Some more also are there. You can read about it. But these are predominant 6 signs which help you in making a diagnosis of 2 things. One is not only thyrotoxicosis, but whether patient has got true proptosis. True proptosis is a problem, is it not? Because if proptosis happens means there is retroorbital deposition of fibroblastic material and all that. So you have to tackle that because the person is going to have exposure keratitis. So you have to tackle that. So that's what it is. So this is what is the reason. You read it. It is called an EPS substance, exophthalmos producing substance, EPS. That leads to deposition of edema fluid and round cell infiltration in the retroorbital space, leading to true exophthalmos, protrusion of the eyeball. Okay? So any questions regarding the test? How to perform and all those things? You will get it in clinic. So this was just the background so that you understand the pathogenesis for the test. Any doubt? Anybody has any question? Signs diagnostic for primary thyroiditis. Read about it. Take myxedema. Remember, myxedema does not mean hyperthyroidism. Isn't toxic. You'll find thickening is there. Then all these things. Dermapathy, clubbing of toes, tremors, outstretched hand. Now when you diagnose thyrotoxicosis, remember that you are supposed to look at the tongue. Supposed to look at the tongue by asking the patient to open the mouth and see the tongue in the resting phase. This is a very important question asked in the exam. Everybody feels that if you have to look at the tongue, you have to ask the person to protrude the tongue. Should never be done. So when you find the tongue is resting in the floor of the mouth and you find those fasciculations and twitchings are there, that is diagnostic. That is one of the earliest signs of thyrotoxicosis. That's how we do. Tremors, is a very, very problematic test. If I ask these people to open your palm and put a paper, 90% of the times it will shake. So you cannot make out whether the person has got tremors or not. It's very difficult. Everybody's hand will shake a little bit. So that's a very good test. But you should be careful that you should not ask the person to protrude the tongue. You want to do that, the examiner will ask how you have done the test, you show, demonstrate, that's a wrong way to show. Okay, so remember that point very clearly. Tremors in the tongue and then outstretched hand. This is what is there. Ophthalmopathy and all those things, this is diagnosed. This is how it looks. Now when the protrusion of eyeball happens, then also like this it will happen. Okay? As I said, whether the stare is because of protrusion or whether it is because of only the stare, the spasm of Muller's muscle. You can only know by doing the Navziger's test. If there is no protrusion, then it's because of spasm. If protrusion is there, that also will lead to this sort of thing. So diagnosis, most cases can be diagnosed clinically. Then raised T3, T4 with undetectable TSH. I already told you the mechanism for this. Why the TSH becomes low. If you do a thyroid scan, the whole gland will pick it up. FNAC, naturally it will be foolish to put a needle in that to diagnose. So sometimes in some patients what happens is they get some treatment outside and they present with us. So when it's not a clear-cut case of thyrotoxicosis, that means it is not the first time you are seeing the patient. If the patient received partly some anti-thyroid drugs, sometimes people will also give thyroxine. Okay, they will not take any thyromegaric, they will give thyroxine in the periphery. So the gland can become a little firm in consistency. When the gland becomes firm, you are not sure whether it is thyrotoxicosis or something else. So in those circumstances, sometimes we do FNAC. If you do FNAC, this sort of picture can be done. Very less of colloid and big cells. Colloid glider is the other way around. More of colloid and flat cells. Here you have large cells, active cells, and less of colloid. And then TSI, those antibodies also you can see in the blood. If you find antibody, it is diagnostic of. So we'll stop here. This will start the next time. Any questions from anybody? Anybody wants to ask anything? Yeah. Tell me. Actually, your voice is not heard. Can anybody just transfer the echo what he is saying so that I can hear? The next part, what you said? What you asked? Navzigus. Navzigus? No, you want to know how we look at it? Or what? There's a chair there, no? Yeah, can you just sit in the chair? Just sit here. Just sit here. Okay. Yeah. See, I go behind the person. Okay? No need. Just to come back. Now see, I'm focusing on the eyebrow. My gaze is parallel to the eyebrow. Gaze is parallel to the eyebrow. If I see an eyeball there, that is positive Navzigus cyst. See, I'm looking like that. My gaze is going parallel to his upper eyebrow, and then I see eyebrow. I ask this person to look up. Okay, when the eyeball is protruding, there are no corrugations on the or wrinkling on the forehead. That is jaw fluorescence. Okay, good.